So I've had the privilege in my life to introduce the father of the internet, Vint Cerf, the father of the cell phone, Marty Cooper, whose wife, by the way, designed the Jitterbug phone. And now I have the honor to introduce one of the foremost scientists of the 20th and 21st centuries, who was one of the first to map the genome. And with that, I'd like to introduce Dr. Craig Venter.
Well, he didn't introduce me, but I'm David Kirkpatrick, here from Techonomy, here to interview Craig Venter, and it's an honor. And in case you weren't aware of this, you're not going to be able to rush the stage because they did not take down the Secret Service barrier. But it is true that this guy is an amazing guy. I actually had on my phone, if I could get it back up, his extraordinary resume. He was a medic in Vietnam, went into academia after that, then went to work at the NIH, started doing rapid gene discovery techniques, and then in 1998 he founded Celera Genomics in order to sequence the human genome, and was really one of the first, or do you say you're the first or one of the first? I know this is a controversial
Clearly
topic.
the first.
Better than the first, yeah. He certainly was one of the key pioneers in sequencing the human genome the first time. And then in 2005, he co-founded Synthetic Genomics, Inc. And then he, in 2006, launched the J. Craig Venter Institute, which is a nonprofit research institute for genomics. And in the last several years, he co-founded Human Longevity, Inc., which is a big part of what we're going to be discussing. And I, in talking to him to prep for this, I was really struck with the sort of, I think, kind of genius of Human Longevity, Inc., which I'm going to ask him to describe in a minute. But it's, as you'll hear, you know, we've started, in large part due to his work, to have this extraordinary resource of human genetic data. But we really don't know what it means. And if you listen to what he's going to describe about what he's doing now, he's continuing his work in genomics, but he's really trying to interpret genomics in a fundamentally new way. So maybe with that, I can ask you to tell us a little bit about what Human Longevity Institute is doing.
Okay. Well, thank you for the kind introduction. And it goes back to when we first sequenced the first human genome. It cost $100 million to do that. It took 9 months. It took a $50 million computer for 1.5 teraflops, and it wasn't a replicable event. The government spent about $3 billion doing a shabbier version, and it was not replicable either. So not much has happened in the last 15 years except incredible technology changes. And I was basically waiting until the computer technology and the sequencing technology got to a critical point. And that's when we started Human Longevity. It was below $2,000 to sequence a human genome. And with cloud and distributed computing, it totally changes what's possible. Our $50 million computer today, you can get a card for your PC for $100. So the time was right. And the key issue was, my genome's been on the internet for over 15 years. There's not much that's understood about it or anybody else's, because we need really large numbers of genomes coupled with clinical and phenotype data to understand it. So that's what we set out to do, is a goal of over 1 million genomes as soon as possible. But in every case, we collect phenotype and clinical data. And we have several sources of this, but I think the main part is we set up our own phenotyping clinic called the Health Nucleus. And it started somewhat naively that we just wanted to measure everything we could on people. But it's turned into such a radical change in what happens in medical discovery that its shift is totally focused. And I can give you some examples, but it's
kind of the most thorough medical examination that anybody's ever done for people, sort of preventatively, right?
That's correct. It's the whole genome, it's the microbiome, it's 2,000 chemicals, complex MRI imaging of your brain, whole body, measuring metabolites as well as cancer. We do CT scans of the heart, CT of the intestine and lungs.
This is all in one day.
All in an 8-hour day. So
it costs $25,000.
there's a $12,000 version that we only do half of you.
I don't know how useful that would be.
But so we do have a cut-down version for $12,500. But the data is really comprehensive. And the thing that surprised us, in retrospect, it shouldn't have, about 40% of the healthy people that come in, we find out they're not healthy. They have cancer, they have major heart disease, they have brain aneurysms.
That they didn't know about, you're saying?
That they did not know about. And so I look at the definition of, everybody here probably feels healthy and thinks they're healthy. That's something out of the Middle Ages. But it's pervasive in the medical profession as well, because if you look okay and feel okay, you're deemed to be healthy. And we get about 1.4 million new cases of cancer a year. Those people didn't just get the cancer the day before. Some have had it for years, some months.
Okay, so you're basically doing the most thorough medical exam that people could possibly have done and using it to correlate that with the genetic data you also examine from them in order to in large part, better understand what the genetic data means. Is that a fair appraisal?
That's a great assessment.
Yeah.
We're trying to interpret the genome so we don't have to do all these expensive tests on everybody in the future. But we know less than 1% of the human genome right now, so we have to have new data to get better interpretation. But along the way, we're discovering a massive amount of disease. But the good news about it, so we have a comprehensive cancer program that we can talk about where people, once they have cancer, we sequence their tumors, we sequence their genomes, we sequence RNA, we develop even cancer vaccines specific for their tumors. But we have 3 women in the 30s that have stage 4 colon cancer. That's 20 years before you're supposed to have a colonoscopy.
That you've discovered through giving them the Project Nucleus?
Well, no, they were diagnosed by getting sick and
they were diagnosed more conventionally. Okay.
At the Health Nucleus, we've been discovering stage 0, stage 1, and some stage 2 cancer that has all been 100% treatable because we're discovering at a stage where it hasn't metastasized yet. And it's such a contrast in the same organization of we discover cancer, individuals know they have cancer for about a week, they have surgery if that's the treatment, and a week later they're cancer-free, versus you discover cancer because it got big, it causes you pain, you go to see somebody. So early screening it's absolutely wonderful, and I'm a testament to it myself.
Well, I want to get to that in a minute. But what strikes me, among other things, and I think it's a fantastic and fascinating effort, but it must take a somewhat brave person to subject themselves to what you're doing if 40% of them turn out to have a major medical condition they didn't know about.
Well, knowledge is power. But it's interesting. Men come in 2 to 1 over women. And I actually thought it would be the opposite, that more women would know if they found something early to do something about it, that they would. But I can tell you, being on both sides of it, it is scary. So my own clinic with a new MRI technique we have diagnosed that I had late-stage prostate cancer. But it hadn't metastasized yet. I had surgery, had it removed, and now 2 months later I'm cancer-free. But
so it was a very rapid process of diagnosis and treatment in that sense.
But it is disturbing when you learn from your clinic that you have something pretty substantial wrong with you. So I understand that part of the fear. The counterpart of the fear is I'm now cancer-free. Everybody else we've discovered cancer is now cancer-free because we found it early enough, not because it caused symptoms. So it's an exciting endeavor, but sure, if you don't go to a clinic, you never go to the doctor, you won't find out you're ill until it's at a late stage and you're definitely ill.
So in a way, in addition to trying to create this revolutionary new correlation between genetic data and phenotype data, you're also really trying to change the attitude of medicine towards prevention and really go radically early into the prevention business, in effect.
Exactly. And we have several physicians that have been angry about the fact that we're screening healthy people. And I said, well, how in the hell do you know they're healthy? In fact, we found out 40% of them are not so healthy. But because we have this primitive view of what the definition of health is, until you show up in the hospital with symptoms, you're healthy.
Yeah.
And I mean, some of these physicians get visibly upset over this because it really turns their entire profession upside down. And the fact that you can find it early, diagnose it, and do something about it, and not just with cancer. We've found several brain aneurysms. Usually people find out about a brain aneurysm when a friend dies suddenly from the aneurysm popping. It's now an outpatient procedure to put a coil in and treat a brain aneurysm. But if you don't know about it, you can't do anything about it.
So you can identify the prospective aneurysm well before it actually generates the crisis.
They show up bright and clear on our MRI images.
Now, has that historically been possible much of any other way?
Well, if you get dye injections, they do show up. The new MRI
If you were
technique-
worried you were going to have it, so
Yeah.
you'd have a cause to do
or
that.
if you were getting a brain scan for some other reason.
By coincidence.
The
yeah.
new MRI technique measures the water molecule differences in tissues. So we get these beautiful pictures of your entire brain vasculature without any contrast media. So we didn't want to use contrast because about 5% of people get an allergic reaction to it. So this new technique can diagnose cancer by measuring water molecule differences, can measure the blood vessels very clearly, and if you got a little bleb off it, that's an aneurysm, it shows up very clearly.
You could call it the, Genetic Expression Institute or something. Why longevity?
So longevity is kind of a catch-all because we're looking at all diseases across the entire genome, and they're actually integrated. And our goal is not just to make people live longer, but to have a healthy lifespan. So a statistic that I'm sure all of you are literally dying to know is about 35% of males will never reach the age of 75 in the US, and about 20% of females, you will not reach the age of 75. 2/3 of the reason for that is a combination of cancer and heart disease. Both are detectable early, both are predictable from the genome, both are treatable early, and those are preventable deaths. Wow. That's a matter of getting the test done and having that be a priority. So that alone will change people's longevity by treating just 2/3 of the reasons people die. And if you think those are odd statistics, just start looking at your high school classes or look at the recent actors that have died in this last year. All the ones that died, other than drug overdoses, were things that would have been readily diagnosed in the Health Nucleus and they wouldn't have died from them. One was an exploding aorta. We see distended aortas all the time. They're surgically treated right away. So it's a matter of looking early. Nobody looked early before because you had to use radiation or some other invasive technique. Now this is completely non-invasive, no radiation, and some of the things are really quite interesting. How many of you have measured your liver fat?
In this crowd, at least a couple. Okay.
But some of you, we've measured it for you. So it's so normal liver fat is about 4% or less. It's very dynamic. And organ fat is one of the key things to knowing whether you're going to live very long. Some of the individuals we have, they have fat levels in the high 30%. The highest one is 38%. He's probably going to need a liver transplant in the near future, completely unaware that they had any disease whatsoever. So we do remote sensing. We give people a little patch they wear for 2 weeks. It records your EKG for 2 weeks. Several people have episodic AFib for up to 8 hours a day. It's the number one cause of stroke. Simply preventable by putting them on anticoagulants now. 2 of them had episodic heart block, where they're basically at risk of sudden death at any moment. Their heart rate would go down to less than 20 beats a minute. And somehow they were unaware of it. I guess they just felt calm or something. So they now have pacemakers. So we're seeing things across the spectrum, but metabolic disease is one of the biggest things affecting all of us for the future.
How many people have gone through this examination thus far?
So we started last January. We're out to well over 400 now.
Okay, and now, while we're on the longevity point, you and Startup Health have a longevity moonshot. And is it basically as you just described, to try to identify particularly heart and cancer illness in advance, or what is that moonshot? Explain that.
So we're looking at, as I said, all diseases. The big ones, though, are cancer and heart disease. But if we measure it, we report it. We're trying to measure every type of disease there is. Between the MRI imaging and the genome, we can tell you whether you're going to get Alzheimer's symptoms 20 years in the future. So we can predict futures with a combination of genomes and these clinical tools. The nice thing is the genome gives you probability statistics. The Health Nucleus gives you yes-no data. You either have it or you don't. And that's helping us get better, more accurate interpretation of the genome.
Right.
So every day our interpretation gets more accurate, and we're able to give people better and more constantly improved information.
And you're also getting phenotype data from outside sources as well as genetic data outside.
Yeah, so for
you're
example,
adding to the database that way too.
Yeah, we're with AstraZeneca and Genentech, we're sequencing their clinical trials. We get phenotype data from that as well as unique data sets. So we're trying to do as many different populations as we can.
I have a curious question. Okay, this is a very medically savvy crowd. Leaving aside the cost of $25,000, which is clearly a factor, how many people in this room would embrace the opportunity to get one of these examinations? How many people find it a disturbing, scary thing they would definitely not want to do? No, only one brave person raised their hand. Okay. Interesting.
Will all of you email me and we'll get back to you
person.
and schedule something for you? So.
But what about the price? I mean, on the phone I said it was expensive, and you said it didn't seem expensive to you, but it is a lot of money, $25,000, right?
Well, when you think about, we have 2 MRI machines, CT scanners, DEXA scanners. You have to have technical people that really know what they're doing. The interpretation of this data is really complex. We're doing it at a very thin margin, if any at all. So it can come down in the future, and that's once we get better interpreting the genome, we can just sequence your genome and say, look, you have these serious cardiac risk. Let's just do the cardiac test on you. Or you have a serious set of mutations in oncogenes. Let's do an annual MRI whole body scan. So there's ways to make it cheaper for the population. But those of you who are really interested in your health, trust me, knowing everything really makes a difference.
Yeah.
Because every one of our systems impacts the other systems.
Right.
And that's why if you just go see a cardiologist, they maybe will help you with your heart. You could still die from heart disease because you're not paying attention to your metabolic systems.
But the real goal is medical diagnosis through genomics, essentially.
It's trying to predict everything we can through the genome.
Right.
I think in the future, this is going to get into predicting life outcomes, personalities, brain types, etc.
Really?
Because all these things affect your disease state. So I knew from my genome I was very high risk for melanoma, but that didn't include the trait of liking to be in the sun out surfing and sailing all the time, which probably quadrupled my risk. So when we measure cancer risk from the genome, we're measuring the most limited things. We're not measuring behavior or other attributes that contribute to things. So we're trying to measure the entire system.
To what extent is this like an AI play in the long run? Is sort of current AI capability one of the key techniques that you're going to take advantage of?
It's going to be essential for understanding all this data in the long term. We're using machine learning now to interpret it. We did a clinical trial on 1,000 people where we took 3D photos of their faces, and we use that as a training set. So if we sequence your genome, we can give you a picture of what you look like at age 16.
Because you've now got that correlation.
That's right.
Wow.
And so we use this as an example of what we can learn from machine learning with a very rich data set. So our goal is to get at least 10,000 people through the Health Nucleus. And then we have tens of millions of parameters to measure on each person.
Well, quickly, we have a lot of other genetic sequencing projects happening at more of a mass scale. 23andMe, the Obama Precision Medicine Initiative kind of thing. Is that basically all additive and contributory, or do you see yourself in effect competing with some of those initiatives, or what?
It's not competitive and it's not contributory. It's like one hand clapping.
Those other efforts.
It's half the picture.
Yeah.
Without the phenotype and the clinical data, the genome is really useful for knowing what percent Neanderthal you are or tracking populations. If we're going to learn and go forward, we have to have all this new data. People pretend we can interpret the genome now. We're at the earliest stages of beginning to do that.
Okay, talk about the kind of long-term plans for HLI. Is the price going to come down? So an expansion is part of the idea, so that all the people in this room really can do it in their neighborhood in the near future, or what?
Well, just a few hours ago, Illumina announced a whole new sequencing machine to replace the X10, and we're in line to get the first set of those. That's going to help drive the cost of genome sequencing down. But once it's below $2,000, whether it goes to $500 eventually or not, I think is not going to have a huge impact. Changing it so that MRI imaging is much more standard. MRI time is pretty cheap. What we pay a lot for is the radiologist to read the MRI images. So we're trying to use AI, so it's a simple computer algorithm that reads that.
Yeah, the radiologists are worried about that, right?
Well, they should be. Fortunately, we have some good ones helping us, but that's what some great people at UCSD did. It's developed something called NeuroQuant. It reads your brain MRI better than any radiologist can, and it measures the precise volume of 20 different regions of your brain. Wow. And so one of the things that's really important for Alzheimer's is knowing the volume of your hippocampus. And so there's whole new parameters now that we measure, and within HLI, people try for bragging rights of who has the biggest hippocampus.
But I know, specifically, you do have expansion plans for what's it called? I'm sorry.
The Health Nucleus.
Health Nucleus, right.
Yes.
But you're going to put it in other cities and possibly countries, right?
Yeah, we're
it's now just in San Diego.
With a lot of different countries and expanding them in the U.S. And we're talking about expanding a mini version of it where you can get your genome done and go to a local radiologist to get the imaging done and send it up to the Amazon cloud, and we'll interpret it for you. So there's ways to get this done on an expanded scale a lot cheaper.
So more partial body examination, in effect,
Yep.
for just the things that you got to worry about.
Or people are concerned. If your mother died from Alzheimer's disease, you're worried that you have Alzheimer's disease. A simple scan of your brain with NeuroQuant will tell you whether you do or don't, and whether you're going to get it in the next 20 years or not.
I think we should go to the audience, since we are sort of in truncated time. Do we have mics ready to go? I see him. Can we get... Okay, this guy's hand got up first, and then we'll go to you.
And while you're doing that, let me introduce my new CEO, Cindy Collins. Stand up, Cindy. Cindy just joined HLI as the CEO. And we're going to work closely together in a partnership. She knows something about business. I know a little something about science, so we're going to work on things. So.
Very cool. Okay, identify yourself.
Hi, Jonathan Darianani. I happen to do the initial incorporation on Illumina. So I've another story. 3 quick questions. Clearly, you're concerned about iatrogenic injuries. Tell me a little bit about what you've done to minimize that in terms of healthy people. Any insight into self-selection, maybe subconscious other awareness of a feeling unwellness that doesn't present to clinical symptoms? And then third, I think there's a great opportunity in behavioral economics for the information you find which is not currently actionable or treatable to communicate that in a way that maximizes positive behavior. It seems like that would be a great research opportunity for those places where it's unclear or uncertain. So
3 rather dense questions, but at least the last one was not a doctor's question. Go
Yeah.
on.
So let me address just one of those. Self-selection is something we worry about. You can appear healthy, but you personally may not believe you're so healthy, but you've never been able to find anything that was wrong with you. So we don't know right now if our data is somewhat skewed by people self-selecting that are worried about disease and yet just kept it their little family secret. So I think we just need much larger numbers, and it's impossible to right now to know what's in people's minds, but it's an important issue.
Yeah, there were several other questions there, but
They were too complex. So
yeah, thank you for saying so. We're not all doctors here, but go ahead.
I'm going to self-select and
Thank
ignore
you.
them. So.
Thank you very much.
So, Andy Gees here. I was surprised you could predict the onset of Alzheimer's because an ApoE3, E4 does only doubles your risk, doesn't mean you're going to get Alzheimer. And also, if you look at the pathology of the amyloid beta, none study shows it doesn't exactly correlate to predicting any symptoms there. So, how do you get to the onset of Alzheimer's with 20-year prediction and accuracy?
So as I said, we use a combination of measuring your hippocampal volume. If you have a lot of voids around it, it's clearly shrunk. We have a whole scale that it goes on, plus looking at a wide number of genes in the genome that correlate with Alzheimer's. The two go together really well.
Are you saying one more question? We thought we had got to go till 4:15. We've only been up here for like 20, 25 minutes. But okay, I guess we only have time for one more question.
No, she said one more hour.
One more hour. Oh, okay. Thank you. And if you're a doctor, ask your question very slowly. Okay. Where's anybody else? Okay. All right. Go ahead. Can we get the mic? Okay, right there. I was going to try not to call on you, Will, but go ahead.
Will Green with Techonomy Media. I write for David.
Yeah,
so
that's
there's
why
a
I didn't
lot
want
of
to call on
different- Is this working? So there's a lot of different longevity initiatives and companies out there. Of the broad ecosystem of different companies and organizations working in this space, which ones do you respect the most and why?
I think the only one I truly respect is Human Longevity, Inc. Because we're not trying to find a magic pill to make people live longer. We're looking at the reality of our physiology, of the complexity of disease, with every tool that's available, plus the human genome. So we're not looking for a magic drug. If there is one, I'll buy it. But I think we're really trying to understand the genome and trying to understand disease. If we could make you live to be 200 years old, we'd have to start sterilizing people at 120.
Somebody else with a question. Right back there, and maybe the mic isn't going to get there, so just shout it out. How about that? Unless the mic is near you. Oh, it is. Okay. And identify yourself.
Sure. Hi. Thank you very much, Alexei Nazem from Nomad Health. Alexei Nazem from Nomad Health. I will preface this by saying I am a physician, and I was the one who raised my hand and said I wouldn't want to be tested. And not because I don't think what you're doing is really exciting, but there's so many statistics out there, for example, that 40% of people die with prostate cancer, 40% of men die with prostate cancer, but not from prostate cancer. Sometimes the running down of positive results can actually lead to greater harm. So I wondered if you would comment on that and talk a little bit about not only understanding the risk of acquiring a disease, but the prognoses of those diseases from the technologies you're developing.
Yeah, no, thanks for the question. And I'm glad you mentioned prostate cancer, because the MRI, this new imaging, only detects high-grade prostate cancer. So it's actually nice. It doesn't detect grade 3 and below. It detects the kind of prostate cancer that you die from, not with. And it's really phenomenal because a combination of the MRI images and ultrasound, those go right into the biopsy center, so you can biopsy exactly where the MRI shows the tumor to be. And it changes it versus I've had prostate biopsies where they take 20 random shots. Every one of them missed my tumor. So until the MRI image showed exactly where it was, there was no way to get a proper diagnosis. So yes, there's a lot of low-grade prostate cancer that people die with. The high-grade prostate cancer, if it metastasizes, there's about a 28% of 5-year survival. So you want to know the difference between the two. the data with the new MRI imaging makes it very clear-cut which is which.
And the diagnostic capability of this new imaging is really amazingly accurate, right?
It's absolutely fantastic, and right now it only exists in La Jolla, but the teams are trying to get it developed so it's on a lot more MRI machines.
I mean, didn't you say 100% accuracy on the phone? Is that possible?
Well, that's what it's been thus far. And interesting, a famous person in San Diego had 0 elevated PSA, and he had an extremely high-grade tumor. Totally credits HLI with saving his life.
Wow, that's surprising. Okay, Esther, please. Esther Dyson, I don't need you to introduce yourself. But you do need a working mic. I don't know.
It's not on.
There?
Yeah, there you
yes,
go.
Okay.
Okay.
So I'm just curious about the non-genotype and sort of non-medical data you're collecting, both, environment, behavior, all the other stuff, because that contributes a lot to the risk as well.
Oh, absolutely. So we have people do questionnaires. It's important to know whether somebody's a smoker or not. Although it's actually easy to tell from a genome sequence from a tumor whether you're a smoker or not. That pattern shows up quite uniquely. So you can't pretend that you're not something. But as I said earlier, environment plays a very key role. 10 years ago, I had a melanoma. It was probably because I spent 10 times too much time out in the sunshine on top of my genetic risk. So we do try and record all those things. But here's the difference. We're trying to solve the simple equation. We can solve everything in the not too distant future that's nature. Everything else is the environment. So the genome will be predictable. Everything will be predictable from that. The environment is 12 orders of magnitude more complex. So we're trying to start with the easy problem first.
Okay, over here. And identify yourself, please.
Yes, I work at GSR Ventures. We're doing
Hold it right up. Oops.
Sorry, I work at GSR Ventures. We are an early stage VC firm. Actually, I wrote to Craig not long ago. But so can I ask a sort of basic questions in terms of how deep do you want to do sequencing to the 1 million people you're gathering data from?
So,
Thank you.
Yeah, I think I understood the question. So for our typical genome sequence with the X10 sequencer, we sequence the genome to a coverage of 30x. And we've shown that gets a very low false positive and a very low false negative rate. With our cancer sequencing, with the cancer exome and the whole genome, with the whole genome we go to 90x in the tumor. But we spike in additional markers as well, so it's even higher, trying to find very rare variants. But 30x with the standard human genome done accurately is more than complete enough.
I'm gonna ask a question that proves how much less medically knowledgeable I am than most people in this room. But what is the biggest challenge you're facing? I just want to know where you see the obstacles to making this kind of system really as transformative as it could be.
So when you think about the amount of data, so at 40,000 genomes, just ACs, Gs, and Ts, we're now at 4.65 petabytes of data. With 1 million genomes, it would be well over an exabyte of data. So that doesn't include all the imaging data, all the lab data, everything else. That's just ACs, Gs, and Ts. So we're already in the 1% group at Amazon, up with video streamers and porn sites. The expansion of computing has to start expanding faster than Moore's Law.
So you just need AWS to get even better faster, in effect.
Yeah, absolutely. We've, I said once before, we blew a hole in the Amazon cloud. But it's a matter of having enough processors available. Their storage is getting cheaper all the time. but the pace of the data collection is outpacing what computing can do to handle it without it being incredibly expensive. So $1 million a month isn't something every biotech company can afford for an Amazon bill.
See, I thought you were going to say attitudes towards prevention, and getting those changed was the biggest challenge. But you don't see that as in super.
There's enough people that are self-interested in doing that they're helping make the case. Trying to change the whole medical system, I'm the biggest optimist in the world, but I don't think that's going to happen. Half physicians don't even follow the basic standard of care in the U.S. So trying to change it so everybody's going to follow preventative medicine. We tried to get the medical school, we offered to do all the genomes of the incoming students. Half the students don't want to know their genomes. How in the hell are they going to help their clients and patients in the future interpret this data? So we're training people, as Joe Biden said, for last century.
Right. I wanted to ask you, since you mentioned, I was just going to next ask you, what did you think about Biden's comments about cancer in particular?
Well, I mean, obviously a tremendously passionate person because of the family tragedy that he lived through. He's absolutely right about government funding of science. It's not the way to move forward. I'm really anxious to see what his foundation is going to do. But I think genome sequencing of tumors, and we're rolling out a major product with our exomes this quarter, of doing the whole exome on the person, whole exome on the tumor, trying to get the price down to $3,000 so people can afford to self-pay. Most hospitals, people refuse genome information because they can't afford it, and insurance companies won't pay for it.
Okay, any other questions from the audience? Because I know we probably are pushing the limit of our time now. Okay, go ahead. Do we have a mic, or shout it out?
I'll just be loud. Rodrigo Martinez with Verisure Genetics. Craig, when a significant part of the whole population in the U.S., when they're born, will be sequenced, what's your best guess? When kids will just be sequenced as they're born?
So it's a real good question, and it gets.
The question was, how soon will every child born have their genome sequenced? In the U.S.
In the U.S. I would like to see it start now. There's a lot of confusing rules about paternalism in terms of not whether you're the father or not. I know you've faced that before, but it's about whether until kids are 18, somebody should know their genetic information. To me, it's absolutely absurd. Knowing the genome in the first 6 months of life saves a lot of lives. Knowing it in the first 5 years of life saves a lot of lives. Your genome is not just your own, it's also your kid's genome in part. And so it should be done as soon as humanly possible. And we're trying to do that in combination with stem cell banking. I think once people see the results of it, that it actually does save lives, it's not just a gimmick to sell something, it will slowly catch on. At least that's my hope.
Anybody else? Do we have more time? I don't know. I guess we do, because I'm not being told we don't.
One more minute.
One more minute.
One more question.
Okay. Well, I have some. I guess I'm still. I guess I just want to hear a little more about the idea of really the correlation. To me, you've spent your whole career, in my mind, pioneering genetic information. But was there a certain kind of epiphany you had that suddenly you had to go at it from the other side?
It wasn't instantaneous, but it happened over time. It was really driven by the synthetic cell project. So that's where we tried to write the genetic code of a cell. We tried to design a cell. It took far longer than we ever imagined it would, but we finally got there. But these cells, driven totally by this synthetically man-made chromosome, have every single function, every type of regulation. They have epigenetics, they have fundamental genetics, everything derives from that linear genetic code. I was leaning more and more that way in terms of our own genetic code. And that's why we call it this. Our DNA software is what drives what we are and physically, but it also drives a lot more about who we are than most people are willing to confess at this stage.
So then you just wanted to explore that.
We have to have the phenotype data to interpret this vast amount of data.
Really cool. Well, thank you, Craig. Really great to hear from you, and I think what you're doing is fantastic.
Thank you.